go directly to the case. This is a case about a male, 68 years old, a bit overweight, with a comorbidity only related with dyslipidemia and diabetes. Clinical presentation, he presented to our ED with the anterior STEMI, gray score calculated as 127, with no previous cardiac history. When the patient arrived, two subsequent ECG showed a clear ST elevation with the right bundle branch block, so the cath lab was activated. And the CAG, as it's shown here in this series of run, was showing a non-dominant RCA with the dominant left circ, with the occlusion of the ostium of the LAD. And the patient at the time was relatively stable. The wiring was easy. And after wiring, the plaque was clearly evident. So we proceeded with preparing the lesion with the normal ballooning, and we proceeded with the stenting at the ostium of the LAD. The flow was clearly restored. Flow was TIMI3. We checked the expansion of the stent with the stent boost tool that I think everyone is using. The final result was relatively, let's say, good. The patient was then transferred to ICU. The echo was showing good performance of the left ventricle with no important impairment. Unfortunately, after 12 hours, the patient developed again critical chest pain. The ECG again is the elevation. We bring him back to the cath lab, and again, there was a clear stent thrombosis with the normal flow on the left circ. The right was not checked again, so we tried to wire. The wiring was again easy. Unfortunately, after the first dilatation of the stent, most probably the patient had embolization of the left dominant coronary artery. So he developed bradycardia, the QRS was becoming large. We inserted the temporary pacemaker, we started CPR, and this was the crucial time where maybe we need to focus on. The CPR was started, the anesthesia team came, we start to assist the patient. They were considering intubation. The timing of intubation was not clear, and during this CPR, the operator was trying to engage the left circ to understand where was the embolization, how to solve it in a brief time. At the time, the Lucas device was not available in the cath lab, so the CPR was ongoing. The patient was not improving. Many dilatations were done on the LAD that was occluded, and on the left circ that was occluded as well. So a minimal flow on the distal left circ was achieved, and the patient was coming back. But again, thrombosis of the left circ, thrombosis of LAD. The patient maybe was not was refractory to heparin, but the ACT we checked during the CPR. The ACT was 250. So again, the operator start to proceed with multiple dilatation of LAD and the left circ. Every time there was a good flow in the LAD, there was occlusion of the left circ. But the patient didn't improve. So again, multiple dilatation. You see the aorta is not moving. The patient got cardiac arrest. We decide to escalate. Firstly, with the bradycardia, we decide to escalate with the EABP, but the patient was not improving. And the CPR was still ongoing. The anesthesiologist was managing the ventilation. After multiple attempts, the flow in the LAD was restored. The flow on the left circ was restored, but the patient got acute cardiac failure. So we needed to escalate again with the ECMO insertion. So the ECMO was inserted, Swan guns was inserted, distal perfusion was performed, and the patient was transferred to ICU. This was the ECG after PCI. Look at that, this minimal flow that we restored was enough, and the patient, now we were observing the patient. The echo showed after 2 days severely stunned the left ventricle, less than 10%. Before was almost 40%. There was no aortic valve movement. There was presence of left ventricular apical thrombus, even if the heparin was started early and there was infusion of heparin. So he developed many episodes of pulmonary edema. There was hypernatremia, achy eye, and the sedation was maintained. The CT of the brain was showing diffuse ischemic injury, and the proper treatment was started. So after 2 days, persistent congestion, he developed anemia due to the ECMO treatment, thrombocytopenia, and we tried even to win the ECMO, but it was failed. The shock was worsening after 5 days. Renal index were deteriorating, hypernatremia, lactate 3.7, even with dual pressor, norepinephrine and epinephrine. This is just the image of the echo after the insertion of ECMO, and this was the presence of thrombus, just to show you. So I will go briefly because the time is going on. This is just the graphs to show how the patient was deteriorating during the ECMO treatment. Take-home message. Early stent thrombosis after primary PCI can trigger a perfusion storm. Be ready to escalate rapidly. VA ECMO saves time but demands left ventricular unloading, anticoagulation targets, and lung-protected ventilation. Neuroprognostication must be delayed and multimodal in the unstable sedated patient, and the statins, this is not important. But team, I want to add the loop communication with the team leaders during ACS in this kind of complication is very important to achieve the success, and even the communication with the family when the patient are becoming complicated is important to prepare them to the worst scenario. Thank you very much.
Thank you very much.